Good morning, everybody. So, welcome to Sri CPD program. So, I will just introduce you today the topic and our housekeeping messages. So, Sri CPD is a national CPD provider, and our housekeeping messages will be keep your mics off always, and keep your videos off, and also this will be video recorded. The webinar's link will be available from 9 to 9:50 a.m. But please join soon because we have a lot of attendees and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to NCCPD guidelines. Thank you for the strict adherence of the CPD regulations and your kind compliance. This is to improve the maintain the standards of the CPD programs conducted by Sri. So I will introduce about asking questions. The question time is at the end of the webinar, and if you have a question, please type it in the chat function. Please change your chat settings to all panelists and attendees so your questions can be answered. If you have very specific questions about your situations and studies, please email us on this email. So today's topic is cancer and non-cancer hematological blood-related disorders by Dr. Saman Hewamana. So Saman Hewamana has recently moved to Sri Lanka from the Royal Medicine Hospital and the Royal Cancer Institute and the Institute of Cancer Research, London, United Kingdom. Royal Medicine is the biggest cancer center in Europe, while their sister institutes are the ICR and is a faculty of the London University. Dr. Hewamana has completed training in the clinical and laboratory hematology in the United Kingdom and holds a certificate of completion of training in hematology. And his name is included in the specialist registry of the General Medical Council as a specialist in the field. He trained in clinical and laboratory hematology in London at the Royal Free Hospital, Whipps Cross Hospital, and North Middlesex Hospital, and in the Cardiff at the Blood Cancer Unit in the University Hospital of Wales, where he subsequently worked as a consultant in bone marrow transplant unit. He has successfully completed membership exams of Royal College of Physicians and Pathologists, where he both being awarded the fellowships. In addition, Dr. Hewamana had a very active research career in University Hospital of Wales and Institute of Cancer Research. He has completed a PhD via a fellowship grant from Leukemia Research Fund in United Kingdom in the field of blood cancer and published several research papers in peer-reviewed high-impact factor journals. He was rewarded by several awards from many institutes in the United Kingdom, including the Gold Medal for Best Research Publication in 2009. He was a member of numerous societies, including the British Societies of Hematology, NCRI, Chronic Lymphocytic Leukemia Trial Subgroup, and the UK Chronic Lymphocytic Leukemia Forum. Dr. Hewamana is a proud graduate from the University of Colombo, Sri Lanka, and has completed his MD before moving to United Kingdom. So we are welcoming you to the Sri CPD webinar, sir, and today's cancer and non-cancer hematological blood related disorders is our topic. Over to you, sir.
Good morning, and thank you very much for the kind introduction. I'm sure that you found very difficult to introduce all the specialties, and I will explain that in my first slide. I'm going to talk a little bit about this complicated specialty, which is a hybrid of general medicine, hematology, and oncology. As you heard, I was a physician here, right? And then step into a specialty which contain skills of or knowledges of physicians or a hematologist and an oncologist. Now, when we talk about blood-related disorders, it's a vast area. Now, I have listed it very brief, oversimplified version of that, which include coagulation-related disorders. This is a plain slide, but I'll talk through this slide. Now, coagulation is, as you know, blood clotting and bleeding. So there are, under the coagulation and hemostasis, is a more complicated word. We deal with patients having clots or people having bleeding disorders. For example, you all must have heard about hemophilia. So hemophilia is a bleeding disorder. And the reverse of that is, you all have heard about DVT. So that is a coagulation or clotting disorder. So under uh, specialty of hemostasis, we have coagulation and bleeding disorders. Then it comes to red cell disorders. The common word is in Sri Lanka is thalassemia. And in the West African region, they have sickle cell disease. Sickle cell disease is not very common in Sri Lanka, but in UK we see a significant number of sickle cell patients due to migrants from Africa. And then I have listed transfusion related issues. Now, that is another specialty with basic knowledge of physicians and hematologists, and people subspecialize into transfusion. They deal with all the transfusion related disorders. Now, when I call transfusion related, now every house officer should know how to give blood, order, when to give blood, how to give blood, and how to deal with the complications of transfusion. But when it comes to bone marrow transplants or complicated transfusion reactions, rare blood groups, there are transfusion specialists. And one of the problems we find in the field of hemophilia, leukemia is people becoming refractory to transfusion. So, for example, now if somebody's platelets count is low, we give platelets and expect the platelet count to go up. Under certain circumstances, they don't increment. So now also I have a patient admitted in a Sri Lankan hospital where the platelets are not incrementing. So those are handled by transfusion consultants. I gave you an example, but it is more sophisticated or complicated than that. Then it comes to blood cancers. Now I have put the word cancer. Cancer is not one disease. It is a collection of hundreds of thousands of disorders. Now, when it comes to cancer, blood cancer plays a significant role because of the scary nature. Now, people get very scared when they hear the word cancer, and when it says leukemia or blood cancer, maybe the perception is worse. Now, I'm not going to tell you all about blood disorders, but I hope that I convince you blood disorders is not only simple or one disease. So it's very complicated, and there are so many different types. I have tried to simplify it and give you some food for thought. So you have to read and think about what else comes down. I didn't touch about coagulation disorders in detail, but I gave you an example like hemophilia as a bleeding disorder or DVT as a clot. And when it comes to treatment also, there are novel or new medications. The old one is warfarin. Now we have something called DOAC, so direct oral anticoagulants, and they are filtering into Sri Lanka. In Sri Lankan market, you have apixaban and rivaroxaban. There is edoxaban, dabigatran, etc. yet to come to the Sri Lankan market. So not only the disorders, the treatment is becoming complicated, and it has carved into a separate specialty. So when it comes to who deal with these disorders, now you should understand it is very heterogeneous. So how can one person deal with all these disorders? The fact is they have subspecialties. There are subspecialists who deal with different types of blood disorders. So they get basic training, as you probably heard from from where I started, like you become a physician, do MRCP or FRCP or do MD medicine in Sri Lanka. That's what I did. And then you need extended training in laboratory and clinical hematology, dealing with patients with blood disorders. And then you can subspecialize. Once you become a physician, a hematologist, then you go into a subspecialty, whether you want to do things related to coagulation, red cell disorders, transfusion, or go into cancer. Now I have put the oncology at the last. That's what I did. So physicians to hematology to, I went to oncology, what is called hemato-oncology. So I am going to concentrate bit more on oncology because that is my subspecialty. And I'm going to leave coagulation, red cells, and transfusions aside. And if you need to know about that, we can talk about those in detail on another day in another lecture. Now, when it comes to oncology, I do the subspecialty of oncology called hemato-oncology. You can see it is the second cause of death in the world, first being heart and circulatory disorders. Though, depending on where you live in the world, maybe cancer is the most frightening word you hear compared to heart and circulatory disorders. Now, you all can think individually to see what you perceive when you hear having cancer compared to when you hear you have high blood pressure or hypertension or ischemic heart disease, though that is the leading cause of death, heart and circulatory disorder. So cancer comes second. I'm not going to go into details about other disorders. What is the risk? This is in US. 1 in 2 men will be diagnosed with cancer. It's a racist disease, so men are more prone to cancer than women. You can see 1 in 3 women in the US, and compared to that, 1 in 2 men. So females get little leverage there. And I have written here on the left hand side of the slide the percentages. You can see breast and lung cancers are the commonest, and my subspecialty blood cancer comes lower down in yellow, 2.5%. But in the world, breast and lung are the leading causes of cancer death. Now, why do people get cancer? I'm going to give a little introduction before I go into blood cancer. There is abnormal growth. So that's what you have heard. But it's not true 100%. There is abnormal growth. And at the same time, particularly in blood cancers, there is abnormality in the cell death. There are certain cancers where cell division is not that great compared to normal cells. Now, the problem with cancer cells are they divide fast and they produce more and more cells. Now, in certain types of leukemias, the growth rate or the cell division is not that fast, but they don't die. So they live longer. So cells can accumulate. A good example is chronic lymphocytic leukemia in CLL. There is a problem with cell production, or what we call birth rate of cells, but the biggest problem is death rate. So they don't die and the cells can accumulate. So loss of normal growth control. Again, like now, I'm not going to go into molecular details about these cells. Then it comes to cancer, and how do you name cancer? We are used to naming cancer on the anatomical location, which is not quite right. Now, as I told, breast cancer and lung cancer are the commonest cancers, or commonest reasons for cancer death. What we call is, if somebody has a cancer in the bowel, we call it bowel cancer. Now, you have heard about stomach cancer. Now, if somebody has a cancer in the stomach, we call stomach cancer. Somebody getting a lump in the breast lump, and we call it breast cancer if it is cancerous lump. Do you understand what I'm trying to tell? So cancer is named on the anatomical basis. That is what people are used to, maybe some of the doctors. That is not quite right. Now, as I told, now I am a specialist in blood cancer. I subspecialize into blood cancers. Now, blood cancer is not always in the blood. So it can be in the bone marrow. When a cancer comes in the bone marrow or in the bone, it is not necessarily a bone cancer. It can be a blood cancer. Similarly, lymphoma is a type of blood cancer. It can come in the breast. So I have seen enough breast lymphomas or thyroid lymphomas. So when you get a cancer in the thyroid, it is not necessarily a thyroid adenocarcinoma. It can be a lymphoma, a type of blood cancer, similarly in the brain. So I'm trying to tell you, I'm not going to go into details again within this hour. It's very difficult to explain everything. There is a WHO classification of hematological malignancies. So blood cancer. Similarly, there are WHO classifications for all the cancer types or most of the cancer types. So in there, we are deviating away from the anatomical classification and trying to move on to a more molecular or gene-based classification or tissue-based or histopathological classification rather than the anatomical classification. For the time being, we probably can escape calling cancer depending on the anatomy. So in liver, all the liver cancers are not hepatocellular carcinoma. So you can have different cancers in the liver. Right. What are the risk factors for cancer? I have listed all. Again, not going into details. You can all read about those. One thing to mention, unfortunately, there are no major risk factors for blood cancers. Smoking is a risk factor for lung cancer, and like no smoking causes lung cancer. Likewise, there is no single or prominent reason for blood cancers, unfortunately. So we can prevent it. So how do you tackle with cancer? How do you know the cancer? Cancer is a diagnosis under the microscopy or microscope. So radiologically, very rarely we can diagnose cancer. Example is hepatocellular carcinoma. If the alpha protein is high, if a CT scan says it is a hepatocellular carcinoma, you can escape without doing a biopsy. But that is a rare example. Otherwise, it is a histopathological or a diagnosis depending on their on tissue. So the tissue diagnosis can come from looking under the microscope or a molecular test or a technique called flow cytometry. We'll discuss that later. And also people talk about tumor markers. Yes, there are tumor markers, but they are not diagnostic, but they are clues to say that there may be a cancer, which are very helpful in screening in some instances. By example is PSA, and also in some instances monitoring the response or treatment. Now, prevention again, like no, this is only for you to think about it and read about it further. In blood cancer, I have nothing to say when it comes to prevention, because most of the time we don't know the reason. Being healthy is important in any cancer, then you will be able to tolerate the treatment better. But being healthy, will it prevent blood cancer? It may be, but there is no hard evidence to show, like in smoking and lung cancer. So don't get me wrong, like no, it is important to be healthy, important to have all the cancer preventive or lifestyle and food, not smoking, not taking excess amounts of alcohol, etc. They are very important factors, but there is no easily remediable factor like smoking and lung cancer. We tell, do not smoke, you will get so many disorders, and lung cancer is one of them. Unfortunately, there is no such strong relationship which can be intervened and prevented people getting blood cancer. Now, when it comes to cancer, we always talk about survival, and most of the cancers are not curable. So we measure their survival depending on how many years a percentage of people will live. Now, one example is, now if I see 100 leukemia patients today, a particular type of leukemia, say acute myeloid leukemia, you have to get the subspecialty or the exact type of leukemia. So if you get acute myeloid leukemia, if I see 100 patients, the success is monitored depending on how many patients are alive after 5 years. Now, AML is not a very good leukemia to have. Generally, the 2-year survival is about 30-40%. So that is the way the survival is measured. And in certain cancers, again, like acute myeloid leukemia will be a good example. If they live more than 5 years, we consider them as cured and we discharge them from follow-up. I hope that you all understood. So we don't tell they are curable, like if you have a lipoma, a surgeon will remove it and you are cured. So there is nothing like that in chronic disorders. So the chronic disorders are the success or the success of treatment is measured by their survival with a defined time period. So there is 2-year survival, 5-year survival, 10-year survival, etc. Now, one factor we know very well is in any cancer, if you diagnose early, the survival is better. So I have given 2 examples in melanoma and in breast cancer. So anybody getting diagnosed early get the survival figures better. But if you get the late diagnosis, the survival is going to be not that good. Right. So I told you few reasons why people get cancer, whether you can prevent it or not. But one fact we know, cancer is a genetic disorder. So cancer is a genetic disorder. Nobody argue about that. Now, some genetic disorders come from your parents. We say that there is a family history. So some genetic disorders are familial or inherited, and some genetic disorders are acquired. So cancer, in most of the cancers, most of the times are acquired genetic disorders. So ultimately there is a problem in the gene. So it's a genetic disorder, but that how that genetic disorder or genetic abnormality happened, it may not necessarily coming from your family. It may be because of something happened after your birth. So what caused this genetic disorder is the question we struggle to understand. Some people, they have never smoked, not taken alcohol, had a very healthy lifestyle, not exposed to radiation, not taken any drugs or medication, prescription medication, which cause or known to cause mutations, but still they get a mutation and end up getting cancer. So how do you explain that? When it comes to diagnosis of cancer, these genetic test we look at genes are very important. I told you cancer is a genetic disorder, but it is not necessarily coming from your families. It's a mutation or abnormality in the gene, mostly after your birth, sometimes coming from families. So what are the techniques? So how do you find out what is wrong with the genes? We have certain test you are familiar with. Karyotype is the oldest genetic test. We still use that, but not that commonly, where you grow cells from the tumor, whether it is from leukemia or myeloma or lymphoma or a breast cancer, or the material which has dividing cells, they try to grow. So it is very popular in blood cancers because we can get the material with dividing cells, but it's not very convenient in solid cancers. I even don't know whether they can do it in breast cancer, lung cancer, etc. Because you need to have a lot of dividing cells to get this technique done, called karyotype. Now, FISH is fluorescent in situ hybridization. You put a probe with a known abnormality and try to see whether that abnormality is there in the patient sample. So that can be done in liquid material as well as solid material, where we can diagnose genetic abnormalities. Again, like no sensitivity of these tests are not that great. So we got the PCR with the higher sensitivity. So again, PCR is, you got very familiar with PCR with the COVID. So everybody knows what PCR is. Even laymen know when they talk about PCR nowadays, thanks to COVID. So cancer doctors use PCR for a long time, and I have done them myself. It's a relatively easy technique where you can look for known abnormalities, and also the advantages you can quantify. You can see with the PCR product the percentage of abnormality, which is very helpful in diagnosing cancer, and also mutations in known cancers, and also in monitoring. So if I give you an example, we use PCR, karyotype, FISH, all these three techniques to diagnose chronic myeloid leukemia. So you probably heard in the medical school, CML happens when there is a translocation between chromosome 9 and 22. And the gene involved is, one is BCR, one is ABL. So BCR, ABL goes near the BCR gene, and there is a gene product which can be measured with the PCR. So when you diagnose chronic myeloid leukemia, we use the PCR to know how much gene product is there. So that tells us the patient has CML and also the percentage of CML. With the treatment, we monitor the product, and we can see whether we are going in the right direction depending on the reduction of the gene product. So that is about PCR. So I'm sure there are maybe people in the audience who are doing more research-based work, who are familiar with PCR and quantitative PCR, real-time PCR, and PCR products. And we used to have gel PCR, which we have moved into more machine-based PCRs now. And the technique or new kid in the block, or the preferred one, is next generation sequencing. It's not very new. It has been there for a long time, few decades, more than a decade, 1 decade definitely. And we use next generation sequencing or NGS, what we call in short form, to look at the mutations. They're more expensive, but more informative and very sensitive in getting unknown mutation. So that is being very widely used in the world. I use them all the time in the NHS work, but the facility in Sri Lanka is not that common. So moving on to more cell biology techniques. So flow cytometry, again, like no, there may be doctors who are doing flow cytometry themselves. I used to do my when I was doing my PhD. So it's a technique where you use a machine to identify cell surface molecules. So there are certain molecules on the cell surface. So depending on those molecules, we can differentiate normal cells from abnormal cells. And that is also very important in diagnosing blood cancers, leukemias. We can't diagnose blood cancer without flow cytometry nowadays. So it is one of the essential components in diagnosing leukemias. And also we use flow cytometry to monitor the response for identifying abnormal clones and also looking for minimal or measurable residual disease. When we can not see leukemia cells under the microscope, these techniques will be able to detect disease which are not sensitive to normal microscopy. So people who are interested can read more about flow cytometry. That is a bit about diagnosing cancers or blood cancers. Moving on, what are the treatment? I'm giving a generic picture here on this slide. So when it comes to cancer, you all know about surgery. Surgically, some cancers are removed, particularly the common ones like breast cancer. You can either remove the breast or remove the lump. So they call lumpectomy or mastectomy. And again, people move from only removing the lump from removing the breast nowadays with the advancement of other treatment techniques. So they remove the lump and give radiotherapy or targeted treatment or chemotherapy rather than removing the breast. That is, of course, in the hands of oncosurgeons. And here I touch about radiotherapy. And then we have chemotherapy. So that is the most frightened word in the world. People get frightened when they talk about chemotherapy. It causes hair loss, it causes vomiting, diarrhea, all the side effects, low blood counts, and sometimes even the death of the patient. So despite all those side effects, that is the main armory of cancer doctors, still we use very widely chemotherapy to treat blood cancers. Now, because of the reasons I mentioned, people move away from chemotherapy and try to develop immunotherapy and what we call small molecules, so more targeted treatment. I'm not going to go into great deal or detail about chemotherapy, but I told you it is still the treatment of choice for most of the cancers, including blood cancers. I'm going to tell you a bit about transplants. That is the only slide I have on chemotherapy. We talk about bone marrow transplant. Bone marrow transplant is not a surgery as widely believed by a lot of lay people and even by some doctors. It is a method of chemotherapy. So bone marrow transplant is a way of giving chemotherapy. Now, the difference between normal chemotherapy or without a transplant and chemotherapy and a transplant and chemotherapy is we take bone marrow out either from the patient, then we call it auto transplant, or from a sibling, brother, sister, or a mud that is mashed unrelated donor. There are donor registries in the world. So we put a notice to those donor registries with the patient's HLA type and look for a donor, or a haplo. Haplo is from parents or from children. So a mother can get a transplant from a son or a daughter, or a child can get a transplant from mother or father. So haplo and cord transplants are umbilical cord transplants. So there are umbilical cord registries where we can request stem cells. So bone marrow transplant, I told, is a way of giving chemotherapy. What we do is we give the chemotherapy to wipe out whole of the patient's bone marrow and his immune system and put one of those, either something we have preserved from the patient, a stem cell sample, or from his brother or sister, from somebody in the world, from the registry, or from parents or children, or from a cord transplant. So that is the only slide I have on chemotherapy, to stress that we can't say like, okay, somebody doesn't need, we don't need chemotherapy. So we spoke about chemotherapy, transplant as a method of using chemotherapy. So the conventional techniques, as I explained to you, surgery has no place for blood cancers. Only we need surgery to do a biopsy. So surgeons can't remove blood cancers due to obvious reasons, like you can't remove lymphoma surgically because lymphoma is a type of blood cancer and in blood goes everywhere. So you can't, thank you, you can't surgically cure a lymphoma or a leukemia or myeloma. But there is a place for surgery in blood cancer. You can use the surgery to get a biopsy, a material for microscopic examination. Then I told about radiotherapy. Then we talk about chemotherapy. And I stopped there and showed you the sample of chemotherapy, a bone marrow transplant, which is a type of chemotherapy. What is the problem with conventional chemotherapy? The problem is the cancer or cancer stem cells can survive. So I told you we look at the survival from the time we diagnose somebody or treat somebody. Later on, when the cancer comes back, we call it relapse. Why do people relapse? Certain very intelligent cancer cells or very cunning or shrewd cancer cells, they can survive or escape without dying. So they go into hibernation and they will stay there, and the chemotherapy is not there or the effect is not there. One cell which has survived can multiply, and then when we can see the cancer again, we call it a relapse. So there are a few problems related to chemotherapy. One, as I told, all the side effects previously discussed. And the second one is some cells can escape and get into, patient can relapse with the cancer. So to avoid those, we have moved into this new era called immunotherapy or novel agents or small molecules or genetically based treatment, etc. So why these novel new drugs or small molecules? They are more specific to cancer cells. So I showed you there are certain genetic mutations. If we can identify those mutations or weak points of cancer cells, we can target those and try to kill cells. They are more selective to cancer cells compared to normal cells. And based on the molecular mechanism, the new drugs are developed. So it is not like for you to understand, using these small molecules or new drugs or antibodies is like trying to murder or kill somebody with using a sniper. Now, sniper can wait, is very slow, but it target is more precise. Now, using chemotherapy is like using a cannon or a bomb. So you come from the top and drop a bomb. Whoever you want to kill also may die, may or may not die. But for sure, a lot of innocent people also die. So that is the equivalent of chemotherapy. There is a lot of collateral damage. But these drugs are more specific and supposed to be not targeting normal cells, though we increasingly see innocent deaths, so side effects related to those drugs as well. I've given you some examples. Don't try to memorize. These are the things I use in blood cancer care in hematology. And you have heard about chronic myeloid leukemia. When I started doing blood cancer work, when I was a junior doctor or a registrar in blood cancer wards, this imatinib was invented in 2001, 2002, 3, more than 20 years back. And that is the drug for chronic myeloid leukemia, which is available in Sri Lanka. Then they have developed dasatinib, nilotinib, bosutinib, ponatinib, besitinib. You can see, like, no, these are not chemotherapeutic drugs. These are tyrosine kinase inhibitors. They recognize the molecular abnormality, then develop a drug to target that molecular abnormality. It's very simple, less side effects. Survival is great and people get cured. Now, after starting TKI, if the cancer is not seen on the molecule-based techniques, for a couple of years, we even stopped these drugs. So the CML, which was not curable, has become curable with these drugs. at least for some patients. Then there are BTK inhibitors used for chronic lymphocytic leukemia and Waldenstrom's and some forms of lymphomas. So these are all targeted treatment. And another one is JAK2 inhibitors. So you probably have heard about JAK2 mutation, and who are familiar with hematology will know there is a disorder called polycythemia rubra vera. So those are JAK2 inhibitors. So JAK2 is mutated in those disorders in polycythemia, myelofibrosis, essential thrombocytosis. Those are types of or names of blood cancers where JAK2 is mutated. So there are JAK2 inhibitors. They are not chemotherapy. Those are small molecules. So we are moving to the immunotherapy and small molecules. These two chaps got Nobel Prize for doing some initial work. I'm going to rush through these slides so I can finish the talk by 10:30. A brief word about antibodies. So you have heard about monoclonal antibodies. Those are newer drugs or newer weaponry in blood cancer doctors' hands. We have monoclonal antibodies which will target one molecule in the cancer. Now we have bispecific antibodies. So I have written here, bispecific antibodies will target will have the ability to target two targets in two different cells. So those are the newer techniques we use to, or newer medication we use to treat blood cancer. If I tell rituximab, people will remember the name. It is a monoclonal antibody. So there is a drug called, very old drug called rituximab, which is used in lymphomas and certain types of leukemias, and also is being used by rheumatologists, by renal physicians. It's a CD20 antibody. So that is a monoclonal antibody which will target CD20 molecule. Now, bispecific antibodies will target two. They have two targets. So they can they have more effect on the killing of cancer cells. I'm going to skip these. These are comparison between monoclonal antibodies like rituximab and the bispecific antibodies. What is the advantage? So, and I don't think any of the bispecific antibodies are available in Sri Lanka. We'll skip those again. Right. This slide, I will go through this. Now, I told you at the beginning, we are used to identifying cancer on the anatomical location, thyroid cancer, breast cancer, lung cancer, liver cancer, etc., which is not right. And we are moving towards finding molecular abnormalities or looking at molecular blueprint of these cancers. And also, one thing for you to remember is, later on I told you, now we are moving away from conventional chemotherapy and we are trying to develop drugs which are more effective at the genetic mutation or the abnormality in the cancer cell. When it comes to this abnormality or the genetic mutations, they are not anatomically specific. Certain types of stomach cancers and a type of blood cancer can share the same genetic abnormality. Because of that, we can use the same drug targeting that genetic mutation irrespective of the anatomical mutation. Now, there is one called PD-1 or programmed death receptor 1 targeted treatment, which is used in certain types of solid cancers and blood cancers. So these drugs are not specific to the anatomical location of the cancer. I'm not sure whether you understand what I'm trying to tell you. Now, more and more, we are moving away from anatomical classification of cancer to a genetic classification. And also we are moving away from these called breast oncologist, blood cancer specialist, or lung oncologist, or prostate cancer doctor to a more targeted treatment-oriented subspecialty. Right. Another thing, a new development about blood cancer care is CAR T cell therapy. So this is a type of immunotherapy, but we are going to, again, like, no, unfortunately, we don't have these techniques in Sri Lanka. Last week, I was working in the UK. So in the center I work, they use this very commonly. I told you in bone marrow transplants, we take stem cells from the patient or from a donor and then give chemotherapy and put that stem cell back and hope and pray that it will settle in the bone marrow and the patient will survive. It has a high mortality, side effects, and it's a type of chemotherapy delivering system, so associated risk. Now, CAR T cell therapies, as I shown in this borrowed cartoon, we take cells from the patient and isolate only T cells and genetically modify those T cells, your own T cells, to go and kill the cancer cells. It's a very clever technique. It's called CAR T cell therapy. So your own T cells are modified and we transfuse it back, so those cells will go and kill the cancer cells. So this is called CAR T cell therapy. It's like a bone marrow transplant. It's like an auto bone marrow transplant, but we are using not the stem cells, but their own T cells to come and or go and attack the cells. So that is a very popular technique and commonly used in developed countries in certain types of blood cancers. Right. So I told all about things which are not available in Sri Lanka. Now, can we do anything in the Sri Lankan setting? May I work mostly in Sri Lanka now, though keeping my NHS job for CPD and the appraisal purposes. Can we do or change the Sri Lankan setting? Is very difficult. And this is not related to cancer. This is related to orthopedics. I hope there are some doctors doing orthopedics in the audience, and these David Cameron people will recognize. He was the Prime Minister of UK some time back. I can't play this video. It's on the BBC. You can find. And the one facing back is an orthopedic surgeon. And this orthopedic surgeon came and asked David Cameron to get out of his ward when he was the Prime Minister, because he came into the ward without permission. And he was so angry, this orthopedic surgeon, I can't remember his name, they showed it live on the BBC, for entering without permission and also coming with the tie and long sleeve. David Cameron, of course, has folded his sleeves. You can see why is that. And the photo in the ward, these bare below elbow. Still he got scolded because his crew was having ties and long sleeves. So infection prevention is very important, and it is very strict in developed countries. There are certain things we don't have in Sri Lanka, but there are a lot of things we can improve by being disciplined. So infection, whatever you do, whether it is CAR T cells or bispecific antibodies, if somebody get a pneumonia, there's a very high chance of death. This is a very old paper I quoted that was in 1966, even before I was born. But this is a fact to the date. So infection alone in this blood cancer ward, the acute leukemia ward, has caused 66%, and infection plus hemorrhage 9%. So about 75% of the people who have died because of the infections. And that is the main cause of death in blood cancer specialty. So infection prevention is very important. So we trained some people from Maharagama. They are consultants now in the Haematological Center in Lanka Hospital, where I visit. And what I told at the beginning was, if you prevent infections, it doesn't matter we're not having bispecific antibodies and CAR T cell and all, we can still save a lot of lives. So infection prevention is very important. Now people have given up wearing masks, but in hematology wards or blood cancer wards, it's compulsory. You need to wear a mask. It's not because of COVID, but there are other more deadly respiratory virus infections. Even a rhinovirus or a common cold virus can be deadly to a leukemia patient. So it's very important wearing masks, wear below elbow, hand hygiene, etc. Then the bleeding. So people, next cause of death is bleeding. People get blood clots and die. So basic hematology training is very important in dealing these bleeding episodes, blood product support, etc. Then the physician skill, like I told you, it's a hybrid specialty. You become a physician, a hematologist, and an oncologist. Metabolic disorders, pre-existing disorders. So when we give chemotherapy, people can go into a lot of metabolic abnormalities. The potassium can go down, sodium can go down. That itself can kill. So when you're hypokalemic, your heart can stop. When you are hyperkalemic, go into tumor with the chemotherapy, your heart can stop. So metabolic disorders. And nowadays, like no, is very uncommon to see somebody without hypertension, diabetes, dyslipidemia, etc. So when you treat the cancer, you have to be very careful managing their pre-existing disorders. Blood sugars can go up and down, blood pressure can go up and down. Those are very important. So the last 4 minutes, I will show you some real data from the practice in Sri Lanka. So with the discipline, like now this was published in a journal by American Society of Clinical Oncology. It's a very the oncology organization, not oncology, it's the Americans. They are Clinical Society of Oncology, and their official journal, one of the official journals, we publish data from Sri Lanka. This one we have shown the time to give antibiotics. So forget about all these bars, and only you have to remember this 20. So neutropenic fever, if somebody's blood count are low, if they come with fever, the time to give antibiotics is 20 minutes. So it is probably you think it's not practical. It is practical. This is real world data we have done in Sri Lanka. So with the right training and giving the authority to nurses, so when doctors, if you wait for a doctor to come and prescribe antibiotics and order from the pharmacy and give it, it takes a long time. So we have a system where we keep antibiotics in the ward, and that is the same way as they do it in the NHS hospitals in the UK. The nurses have the authority to give the first shot of antibiotics that save lives. So the target is to give within 30 minutes. In this paper, we showed that we have done it within 20 minutes within the target, and without any difference between whether it's during the day when you are awake or in the night when you are asleep, or when it is weekend with less staff, or weekend during the night, which may be the worst, less staff and sleepy, but still we are managed to do that. So that is one of the main reasons or main targets of preventing death with neutropenic sepsis. This applies to UK, to US, and to Sri Lanka. Wherever we need to give antibiotics very quickly, and before that, we need to do cultures, etc. So this is again, like I told you that certain things we don't have the treatment modalities in Sri Lanka, but this paper was published again in ASCO journal. This is Sri Lankan real world data. There are large number of doctors. These are Sri Lankan colleagues. We have a group practice, so we work together, physicians, hematologists, oncologists, a lot of doctors from Maharagama, etc. This is in myeloma. So the myeloma is type of a blood cancer or plasma cell myeloma. You're probably more familiar when I call multiple myeloma. And the treatment first line in the UK is a 4-drug combination called Dara-BTD, and that Dara is very expensive, so we don't have Dara in Sri Lanka, or Daratumumab is extremely expensive, so we use the VTD. So in UK, the standard first line treatment is Dara-BTD, and we use only VTD, but still we have shown we can have comparable survival parameters. I explained to you previously what is survival compared to Western countries. If you are more disciplined, you prevent deaths from infections, metabolic disorders, bleeding, and clots, etc. Same, I'm not going into details. This is related to Hodgkin's lymphoma, Sri Lankan data. I'm giving you some positives at the end after telling what is not available in the Sri Lankan setting, but still we can have comparable survival of data in Hodgkin's. Of course, it is a curable lymphoma. Certain blood cancers are curable. Hodgkin's is curable in about 90% of the time. So we can achieve that in the setting of not having enough resources or money. Same applies to leukemia. I can't go into details about this study done in Sri Lanka due to the time constraints. This is in a leukemia called acute myeloid leukemia, or AML. I gave you an example when I was talking about survival. So acute myeloid leukemia is not one thing. Depending on the genetic basis, there are different types of acute myeloid leukemias. But overall, we have done in par with Western data with limited resources. Same with the bone marrow transplant. This is the EBMT, is the European Bone Marrow Transplant Registry, or their meeting. We presented this poster related to what happened in transplant when we don't have money, and still we can have very good results with the prevention of common ailments, or preventing patients dying from infections, bleeding, clots, and metabolic disorders. I will skip that. The last slide, or last two slides, is related to last slide is related to again some positives. Recently there was a song by blood cancer survivors in Sri Lanka. It is not all doomed when you hear the word blood cancer. Most of the blood cancers, all of the blood cancers are treatable. Some blood cancers are even curable. Thank you very much for listening. I'm sorry, I have to rush through the slides and didn't have time to explain everything for your liking. Thank you.
Thank you so much, sir. So we will start with the Q&A session, and we have few questions in the chat box. And the first one is, she would like to know early diagnosing in primary level, like how we diagnose in primary level.
Primary liver cancer, the early diagnosis is you have to recognize the risk factors. So now, if somebody who is well without having a liver disease, it's very difficult to diagnose early. So you have to get the target population. Somebody is cirrhotic, or in UK, I can give an example. There is a disease called hemochromatosis. So you probably have heard about. It's an iron overloading condition. Primary or hereditary hemochromatosis is a genetic disorder, very common in Northern European or white Caucasian people, rare in Sri Lanka and Asian countries. That is a reason to get liver cancer. So in the hemochromatosis patients, we manage them as hematologists, keeping their iron low, will keep their liver cancer at bay. So those people, we can do ultrasound scans, we can do alpha beta proteins as tumor markers. So in a targeted population, scans, alpha beta protein will help. But there is no universal screening technique or screening program in the UK for liver cancer. We have that for pap smears. We have the breast screening mammogram. Now, recently they started lung cancer screening they do the bowel cancer screening or the fit testing. For liver cancer, there is nothing, no screening. When it comes to the normal population, we call screening, but if it is a target population, we call testing. So early liver cancer is not screening, it has to be testing in the high risk population.
Thank you, sir. So, regarding the hematological cancer, like how do we like diagnose it in the like outpatient level or at the basic level? How to identify it and refer? So, where to identify it like that?
Yeah, so again, like no, there is no screening program for blood cancers. As I try to explain to you, when I started doing hematology or blood cancer work more than 23 years back. So I've been doing 23 years back blood cancer. When I was a very junior doctor, one of the professors in Royal Free Hospital, before I went to Royal Marsden as a consultant in my training, told leukemia is like an animal in the jungle. So which one you think about when I say like, no, there's an animal in the jungle? It could be anything, isn't it? So your question is very reasonable. Even sometimes I struggle to guess whether it is necessary to do all the tests or whether I do a bone marrow, whether I do a MRI, whether he has got a blood cancer or not. With all this experience, still I struggle to decide about that. So blood cancer is very variable and there is no one test. It can be a leukemia, lymphoma, myeloma. So what I suggest is like, no, your history, basic history. Now, if you suspect myeloma, the backache and the age of the patient, whether there is proteinuria, kidney damage, do a calcium, do an ESR, likewise. So the leukemia is relatively easy because you can do a full blood count. Most of the leukemias, the blood count will be abnormal. The dreaded one is lymphoma. When it comes to lymphoma, it's extremely difficult. I remember, as I told, I started as a physician when I was doing MRCP and MD medicine in Sri Lanka. Uh, we get these cases, the written long cases, short cases. If you don't know what it is, we always try to think whether it is a lymphoma. The patient has multiple complaints. We don't know what is happening. We like know the colleagues, like know my physician colleagues will remember. Here we used to say either it is going to be a rheumatological disorder or lymphoma.
Yes, thank you, sir. So, the next question is in myeloproliferative disorders, hepatosplenomegaly is due to because of hematopoiesis or due to excess destruction of cells in these organs?
Yeah, so that's the same, isn't it? So hematopoiesis is excess, excess destruction is because of the excess production.
Okay, yes.
Yeah, it's excess production. So in myeloproliferative disorders, well, good example is myelofibrosis. So when the bone marrow get fibrous, your extramedullary hematopoiesis get active, but they are not very efficient. So they get like no liver get massive, and then again it also get fibrous, and like no the production is not very efficient. So it is because of the production. And like no again like no good that you told that myeloproliferative neoplasm. Now when we were medical students or when I was a physician in Sri Lanka, we had polycythemia, myelofibrosis and ET, and CML also unfortunately in the same group. Now CML has moved to a different chronic myeloid leukemia with the identification of these new drugs and the genetic mutation. It get BCR-ABL mutation. Now, similarly, myeloproliferative neoplasms are also getting recognized as genetically mutated distinct disorders. Now, we have JAK2 mutated myeloproliferative neoplasms. We have CALR mutated. I'm not sure whether the person who asked is familiar with all this. You can easily read and see. Then we have MPAL mutated ones. JAK2 also there is V617 and exon 12 mutation. So what I'm trying to tell is now we call myelofibrosis, ET, polycythemia in a different criteria. Now it has come under genetically classified criteria. So there are CALR mutated myeloproliferative neoplasm. It could be polycythemia, myelofibrosis, or ET. Yeah.
Yes,
So it is
thank you.
getting divided or classified very different to what we learn.
Yes, and so there's another question like, is microplastic cause increasing risk of blood-related disorders?
Micro,
Microplastics.
well,
Microplastic.
it is implicated in all the cancers.
So, and next one is, what are the
I'm sure it
antibiotics?
is implicated in blood cancers as well.
Yes. So, what are the antibiotics for cancer patients who have neutropenia?
All right, that's a very good question. Now, when I went to UK, I did my MD medicine. I was a senior registrar. Then I went for post MD training, and I asked this question from microbiologists. Thank you very much for the person who asked this question. I still ask from microbiologists in Sri Lanka. When I went there, neutropenic sepsis, first line is piperacillin tazobactam. First line in 2002 was piperacillin tazobactam for people who are not allergic to penicillin. So you have to make sure that they are not allergic to penicillin, not meropenem, not ceftriaxone, nothing. So it is piperacillin tazobactam. There are exceptions if you are allergic to penicillin. So that is the antibiotic. So for neutropenic sepsis, I was working there last week.
Okay,
And
so
I
thank
came
you.
only on Thursday. Still the first line is piperacillin tazobactam. Now we talk about this antibiotic resistance and various antibiotics in the NHS last more than 20 years. That is the drug, piperacillin tazobactam. That is the neutropenic sepsis first line. If they are hypotensive, you add aminoglycoside, amikacin or gentamicin, aminoglycoside, whatever you are familiar with. If they have a line, Hickman line, port or a PIC line, then you add a gram positive depending on the culture. And without the culture evidence, you do not change.
Okay, thank you so much, sir. So next one is, what are the leukemias that has worse prognosis and good prognosis with treatment?
Yeah. So every leukemia, if I say within that leukemia, there are other risk factors. Now, I will talk about acute myeloid leukemia again. Like I told you, acute myeloid leukemia is a leukemia with a dreaded prognosis, very bad prognosis. But inside that, there is acute myeloid leukemia with standard risk, good risk, and poor risk. So if you have a good risk acute myeloid leukemia, it is all defined genetically nowadays. Like if you have inversion 16 acute myeloid leukemia, that is considered as a good risk acute myeloid leukemia. There is a good prognosis. Now, if you have a complex karyotype or a lot of genetic abnormalities, that is a poor risk acute myeloid leukemia. So it is very difficult to tell, okay, ALL is good or AML is bad, myeloma is good, lymphoma is bad. Likewise, you can't say.
Yes,
So
thank
it
you.
depends on the genetic blueprint, and the AML can be good or bad. If you want a simplified answer, not a lymphoma, not a leukemia, Hodgkin's is still 90% curable.
Yes, thank you, sir. So there's another one question, the last one. Please explain the correlation with immune diseases with hematological cancers.
Yeah, again, a very good question, and it's a completely different lecture if you want to tell me, give me. There is in the WHO classification, the new one, and even the old one, there is a separate section of lymphomas, immunosuppression associated lymphoma. So when your immune system is reduced due to treatment or disease, the treatment is like, no, there are people may don't get scared now on methotrexate for rheumatoid arthritis. Long term, there is a risk of getting lymphomas. So when we suppress your immune system, cancer cells can escape. That is common sense, isn't it? So our immune system is keeping cancer cells at bay. So immune system is not right, then the cancer cells can survive. So immune suppression associated lymphoproliferative disorders are there. You probably have heard about PTLD, that is post-transplant lymphoproliferative disorders, which can happen after kidney transplant, liver transplant, even bone marrow transplant. So that is not because of the transplant. We call the PTLD, post-transplant lymphoproliferative disorders, or post-transplant lymphoma. Nothing to do with the transplant. It is to do with the immunosuppression. With the transplant, we suppress the immunity. So the new classification is, or new way of calling it, is immunosuppression associated lymphoma. So any cancer can come. Lymphomas are the commonest. And also it could be because of another disease. Now we know for a fact that HIV, people with HIV or AIDS get lymphoma. So they get Burkitt's lymphoma. They can get any lymphoma or any cancer because of the immunosuppression, not because of the medication, but because of the disease. Does that answer your question?
Yeah. Thank you, sir. Thank you so much for your contribution. Like it was a very informative and it was a very good so we will conclude for today. So thank you very much. So I am thanking today the Dr. Saman Hewamana, the consultant hematologist, clinical hematology and clinical oncology. The topic was the cancer and non-cancer hematological blood-related disorders. So thank you so much, sir, for today's contribution. And if you have please see the link for the e-certificate we have shared in the chat box, so you can fill it and send us to get the e-certificate. And please note that we will not be able to send the certificate by today, but we will send it to you soon. So thank you very much everyone for your participation, and also thank you, sir, again for your contribution and for the informative lecture. So thank you so much. So we will end up for today. So we will meet next time with a new topic. Thank you.